Now, in continuation of the vertebral body pathologies, the next condition which we discuss would be ankylosing spondylitis. The ankylosing spondylitis is defined as a chronic multi-system inflammatory disorder involving primarily the sacroiliac joints and the axial skeleton, that's the vertebral column. The characteristic feature of ankylosing spondylitis, differentiating it from the other spondylitis, would be in ankylosing spondylitis, the symptoms will improve with exercise, whereas in the other types of the spondylitis, exercise aggravates the pain. And in the ankylosing spondylitis, pain will be more at night, whereas the other way, in other types of spondylitis, it will be somewhat better at night. The onset of pain is insidious, usually with low back pain, which may last for at least 3 months, which is the most common initial symptom. And then most of the times the patients are of younger age, below the age of 40 years, and rest doesn't improve the condition. Stiffness of the spine and kyphosis resulting in a position which is very characteristic, which I will show you some of those images like. Then peripheral enthesitis and arthritis. Enthesitis is the inflammation of the tendon insertion. There again, the more common are the Achilles tendon insertion, where the patient would have the pain in the beginning, and the other joints also could be involved in the patient's ankylosing spondylitis. And many times extra-articular manifestations, joint pathologies other than that of the joint, like the eyes, uveitis or conjunctivitis also may be common. The exact cause for the ankylosing spondylitis is not known, but there is supposed to be 3 factors: genetic, environmental, and the occupational factors are considered to be the issues. As far as the genetic are concerned, there is a very strong belief that the gene HLA-B27 is having a direct relationship with the onset of ankylosing spondylitis, but this relationship is not uniform in all types of human beings or all types of these types of the personalities. Is having somewhat better relationship with the European races, but in Indian conditions, that relationship with the HLA-B27 with the spondylitis is not so much as such. That's what the data, universal data shows. Of course, we do not have a specific data about Indians, but the Indian data also is on the same lines, like in the white races, albinos, the relationship with the HLA-B27 is as high as 92%, whereas with the pigmented races, Africans and Indians, it's less than 50%. So, but still, in practice, majority of our doctors, Indian doctors, they go for the HLA-B27 investigation in all the patients of suspected ankylosing spondylitis, which has now lesser clinical relevance. It doesn't develop, the spondylitis doesn't develop with every person who has HLA-B27, and this is true in India. Majority of the patients who may have HLA-B27, they may not have the spondylitis, but unnecessarily they are named as spondylitis condition, and hence clinical environmental factors are considered to be more important. And it's absolutely true, many of the patients, they may be HLA-B27 negative, but still they may have the symptoms, and most of the times it is the diet which is important. And even the first degree relatives who are of HLA-B27 positive do not uniformly develop the disease. In fact, only 15 to 20% of such individuals develops the disease. These are the data which are available from authentic sources. But still, HLA-B27 is considered to be one of the standard investigation pattern. Now, one of the new thoughts coming up in case of the ankylosing spondylitis etiology, the environmental factors, particularly GI tract inflammation and elevated immunoglobulin antibodies against Klebsiella, they are now having a greater relationship with the GI tract or this ankylosing spondylitis. ultimately it's the status of the colon and the condition of the colon which is responsible for the ankylosing spondylitis. So importance of the colon and the healthy condition of the colon, the microbia in the other diseases is one of the new area which is coming up. Primarily it substantiates the concepts of Ayurveda, where the kosta is considered to be the origin of all the diseases, particularly Vata Vyadhis, where Pakvashaya is considered to be the source. And the technology of treating these conditions with the Basti can be justified in future if these kinds of new thoughts are coming up. And there are now lots of very authentic these articles coming up about the status of the intestinal condition and these rheumatoid pathologies and ankylosing conditions as such. These are certain of the very valuable references. Those who are interested, they may read these articles. Then other environmental factors which are known to trigger ankylosing spondylitis are the pollution, then nutrition, diet, particularly diet. In the diet, added sugars, high sodium content contents, trans fats, saturated fats, which are all the common contents of the packed food substances, which we call as junk food. So junk food is directly related to the ankylosing spondylitis pathology. Trans fats particularly, again, very important, and high protein containing diet like chicken also is known to have a triggering factor. Cold weather, humidity or extreme heat conditions, and very important another is the drugs like NSAIDs. Usually patients with some chronic pain, they are prescribed NSAIDs as the routine prescriptions, and those who are on NSAIDs for long duration, they may develop many complications, and one of the very common complications would be spondylitis, ankylosing pathologies developing in patients who are on NSAIDs. That's a very important thing. A patient of ankylosing spondylitis can also have the other symptoms like other system may have uveitis, where there could be irritation in the eyes, or cardiovascular diseases, pulmonary diseases, renal, neurological disorders, gastrointestinal disorders, metabolic bone disorders like osteomalacia. They are very commonly coexisting. So in a patient is presenting with the ankylosing spondylitis signs, it's also necessary to examine the other systems and rule out those other pathologies. The typical clinical presentation of ankylosing spondylitis is initial onset of low back pain and usually the symptoms occur at a younger age. Presence of symptoms are more than 3 months. Symptoms worse in the morning or with inactivity. Improvement of symptoms with exercise. The commonly involved sites in the beginning would be either Achilles tendon insertion or insertion of the plantar fascia or calcaneus, which are again very common clinical symptoms in our conditions. A large number of patients presenting with this pain in the heels, and particularly pain in the heels in the early morning hours, and a pain which reduces after exercise. That could be the initial beginning of the ankylosing spondylitis, amavata. From our point of view, that's a sign of the amavata. Then the base of the first metatarsal head, tibial tuberosity. These are the other areas where the patient may have pain, which are often wrongly diagnosed as simply arthritis. Then over the patellar surface or iliac crest, these are the other areas. Less frequent sites where the pain could be felt would be greater trochanter, ischial tuberosity, costochondral junctions, the distal portion of the scapula, epicondyle area, or ulna. These are the areas where the patient may feel the pain in some of the conditions, rarely. Other joints which could be involved, again, could be shoulder girdle, particularly glenohumeral and acromioclavicular joints. Those patients who present with the shoulder pain very often, they may have the ankylosing pathology. Costovertebral joints, costosternal joints, manubriosternal joints, symphysis pubis, temporomandibular joints also could be involved, where the patient may have the pain in any of these joints, and often they mimic the conditions of arthritis. The usual range of presentation would be 90% of the patient would have a back pain which is of inflammatory origin, and buttocks pain is in about 80%. Enthesitis is pain in the area of insertion of the tendons is about in 85%, like the Achilles tendon and so on. Peripheral arthritis, other joints being involved in 35%. Dactylitis or eye signs in around 17%. Simply fatigue as a major symptom in 50% patient. Because of these variable clinical presentations, the diagnosis is based upon the clinical criteria. There are two patterns of the criteria, two popular criteria to make the diagnosis: New York criteria and Rome criteria. Majority of the Indian neurologists, they follow the New York criteria, but if you read the textbooks published from England and the European conditions, the Rome criteria is followed. The differences are not much as such, but there is certain specific differences. According to the New York criteria, patient with low back pain with inflammatory characteristics, limitation of the lumbar spine movement in the sagittal and frontal planes, decreased chest expansion, sacroiliitis grade 2 or higher, or unilateral sacroiliitis of grade 3 or higher is considered to be a definite ankylosing spondylitis, and particularly when the sacroiliitis of grade 2, grade 3, unilateral or bilateral is seen, that's confirmatory. Whereas in the Rome criteria, almost similar issue, but there is some more definition: low back pain and stiffness for more than 3 months, that's not relieved by the rest. Then pain and stiffness in the thoracic region, limited motion in the lumbar spine, limited chest expansion, and history of uveitis, and diagnosis of ankylosing spondylitis when any clinical criteria present with bilateral sacroiliitis grade 2 or higher. This is, of course, not much of a significant issue. These differences are only academic, but the important point is a patient presenting with the sacroiliitis symptoms where the pain is in the sacroiliac joint area, not in the midline, away from the midline, or those patients who have the tendinitis, ankylosing tendinitis or fasciitis like symptoms. Then to confirm about this, there is another clinical criteria, scoring conditions. Again, GSSG criteria and MR criteria are also the other way. Of course, these are all only from the academic point of view. To give the scores, like if the patient has inflammatory spine pain or inflammatory back pain, 1 point; alternative buttock pain or unilateral buttock pain, 1 point; enthesitis is 2 points; sacroiliitis again 2 points; this irritable bowel disease or peripheral arthritis 2 points; positive family history, dactylitis, acute anterior uveitis, HLA-B27 positive history. These are given scores, and based upon that, a diagnosis spondyloarthropathy with 6 or more points is considered to be ankylosing spondylitis. But more important at the typical clinical presentation, the typical posture of an ankylosing spondylitis, particularly which involves the cervical spine, would be of the sort where the patient would have a flexed neck. The back also would show a sort of flexion deformity which involves the thoracic segment. This is very characteristic, and reduced range of movement of the neck. The neck extension would be very low. The other signs are enthesitis signs, local pain at the, and even there could be tenderness or even a mass, relatively firm mass felt at the Achilles tendon insertion area, which could be confirmed by the MRI, the tendinous inflammation at the area of insertion of the tendon at the bone. That may be typically seen either at the superior portion or at the lower portion. These could be the obvious clinical signs in case of ankylosing spondylitis. Radiological confirmation would be by confirmation of the sacroiliitis, either unilateral or bilateral. In the unilateral sacroiliac joint, you should see the inflammatory changes, or bilateral where there is a marked severe grade 2 type of the inflammatory changes in the sacroiliac joint, which could be either confirmed by plain X-ray or CT. In the CT, again, you can see the same sacroiliitis images, which can be better seen. This CT gives you a better image of the sacroiliitis, inflammatory changes in the sacroiliac joint, much better than the plain X-ray. Or another of the typical clinical sign is the annulus fibrosis. That's the intervertebral discs throughout, they become ossified, and hence they become opaque as you see in the plain X-ray. And as a result of that prolonged opacification, the intervertebral joints seem to be prominent, bulging at the area, and there would be a significant nodular bulging at the segments, intervertebral segments, which is often called as a bamboo spine pathology. So X-ray image will show something like the nodes of the bamboo as such, and that's why it's called as bamboo spine. And that ossification can also be confirmed by a CT or MRI, but better than the plain X-ray. In the CT, you can see these bulgings much better. Even the involvement of the fibrinous portions, the collagen tissue also can be better made out with the CT, which is as such. Then the next stages, as it advances, the changes in the bones also, intervertebral joints, result in osteophyte formations, which is, and the joints, they tend to become flattened, and that's very typical, which we call as syndesmophytes. The intervertebral bodies would show a increased deposition of the calcium at some area, and there would be the osteophytes, projections, and this also is called as Romanus lesions, which can be better made out with the CT. Even in the plain X-ray, these can be made out, which could be a sign of ankylosing spondylitis as such. So radiological signs of ankylosing spondylitis could also present with the other joints, involvement of the other joints like the elbow joints, or even the phalangeal joints could be involved, along with the involvement of the vertebral sacroiliac joints. That confirms the ankylosing spondylitis. The ankylosing spondylitis may also occur as a secondary lesion. So primarily the disease could be something else, but later it may result in ankylosing spondylitis. This also is quite true. Reactive arthritis, around 60 to 80% of the reactive arthritis patients of different degree may progress into ankylosing spondylitis if they are not treated properly. So in such conditions, that history is quite important. And psoriasis is accompanied by spondylitis in around 60% of the patients. There again, the primary pathology could be psoriasis. Patients with colonic pathology, particularly IBD or ulcerative colitis, they too develop the spondylitis quite frequently. And there again, when it comes to the assessment as well as the management, these primary conditions have to be considered. Acute anterior uveitis, eye conditions, where the uveal junction would be inflamed, and of course undifferentiated, where you cannot make out like whether there is a primary or secondary. That's whether the ankylosing spondylitis has occurred as primary or secondary, still it remains in around 20 to 22% ranges. Morbidity in patient of ankylosing spondylitis is mainly involvement of the spinal or peripheral joint involvement, or rarely due to the extra-articular manifestation like cardiac involvement or pulmonary involvement also can produce that. A poor prognosis in all cases of ankylosing spondylitis, once you have made the diagnosis, the prognosis can be predicted, and particularly poor prognosis is predicted based upon one, peripheral joint involvement. The patients who have only the involvement of the vertebral joints, they have comparatively better prognosis, whereas if there is a peripheral joint involvement, the prognosis is poor. Younger the age of onset, prognosis is poor. Then elevated erythrocyte, ESR being raised, is also a sign of poor prognosis. And of course, if we are giving NSAIDs and if the patient has shown poor response, that too is suggestive of poor prognosis. Majority of the patients who come to Ayurvedic hospital, they would have taken NSAIDs earlier for a long duration, and because they do not find a relief, they come to Ayurvedic treatment, and in such conditions, naturally, the prognosis would be poor. From the treatment protocol point of view, from the contemporary system, the drugs which are used are primarily the non-steroidal anti-inflammatory drugs, or sulfasalazine, or now the newer generation of the drugs like tumor necrosis factor alpha inhibitors, like etanercept, which is very costly, or infliximab also are being prescribed. Then genus kinase inhibitors, newer generation drugs, which are again very recently introduced drugs like tofacitinib or ipadacitinib. These also are now rarely being prescribed, which are again quite costly and toxic also. Then interleukin 17 inhibitors like secukinumab also is now being prescribed. These are the new generation drugs, which are claimed to be very beneficial, but also they are quite toxic. Then surgical therapy is the other option, where either it could be vertebral osteotomy, where the patients have involvement of the cervical or thoracic spine. The osteotomy can help in increase the range of movements, or stabilization, fracture stabilization if there is a fracture, Replacement of joints are the other options depending upon the patient's presentation. When we treat the patients, very often ankylosing spondylitis patients would have a definitely better response compared to the contemporary system, and my usual prescription would be considering this as a variation of Varmamata, the Gokshiradi, Mrityunjaya or Vishamstuti, or many times both, depending upon the patient's intensity of the symptoms. Vishamstuti as a pain relieving drug, Amsarista, Agnachikisa Ksharbasti, and almost every patient would have a significant relief, though there may not be a complete cure. I don't say that a patient of ankylosing spondylitis can be completely cured, but the quality of the life will improve and the symptoms will be relieved significantly. The next condition, and probably the last condition in our neurological discussion, is spinal cord injuries. Spinal cord injuries are defined as an insult to the spinal cord resulting in a change, either temporary or permanent, in its normal motor, sensory or autonomic function. When there is an impairment of the function due to some injury to the spinal cord, which is either mechanical injury or the chemical injuries or maybe the ischemic vascular injuries, that is considered as a spinal cord injury, and it could be manifested due to mainly three mechanisms: either direct trauma or mechanical injury, compression by bone fragments or hematoma or disc material. Though there may not be a direct injury, but it may be compressed, the spinal cord compressed, and a large number of patients whom we treat in our conditions are of this sort, where there could be a compression by the intervertebral disc materials or bone fragments, hematoma, etc. Ischemia from the damage of vessels, spinal arteries, either thrombosis or impingement, arteries may be blocked. The other etiological factors, other conditions, vascular disorders, tumors, infectious conditions, spondylosis resulting in the spinal injury, then iatrogenic injuries, particularly when you give spinal anesthesia or maybe epidural anesthesia, etc. Then vertebral fractures or secondary osteoporosis, that's one of the important issues. Trauma is the other issue. Developmental disorders are other issues. When we consider the injuries, spinal injuries in India particularly, among the traumatic causes, motor vehicle accidents constitute the majority. 56% are from the motor vehicle accidents, and the other accidental falls like from a tree or so on, it's around 14%. Firearm injuries like bullet and other weapons which are used, 9%. Sports injuries around 7%. This is the data from India in 2014. Of course, this may change according to the lifestyle factors. Approximately 10 to 20% of the patients who have sustained spinal cord injury do not survive to reach the acute hospitalization. That means when there is an acute trauma like road accident or fall or so on, around 10 to 20% of the patients die at the spot, or before hospitalization there may be a death due to the acute complications, whereas about 3% of the patients die in the hospital during the acute stages because it becomes unmanageable, even with the best of the facilities. Now, when a patient comes to you with an acute injury like a trauma, comparatively the incidence of such conditions which we see in our hospital is lesser, but still you have to have some idea like what should be done. A patient of spinal injury, when it is brought, of course the first of the thing is moving the patients of spinal cord injury itself requires some skill. You have to ensure that the condition of the patient doesn't worsen. So mobilization of the patient from the site of injury to the hospital itself requires a specific skill where the injured portion has to be given a support and the movement at that area has to be avoided. Now, once the patient is brought to the hospital, the first of the primary job would be to consider the evaluation of the pulmonary system. Most of the patients die due to failure of the respiratory system, either because of the injury at the cervical segment or maybe due to the hemorrhage which occurs into the area, and hence the respiratory failure is the most common cause of the death, immediate cause of the death after the spinal injury, and hence the first of the thing is a pulmonary evaluation. You have to confirm whether the patient's respiratory system is capable of surviving on its own, or whether it requires some interventions immediately. Usually, with the high lesions like cervical 1 or 2, the vital capacity could be as low as 5 to 10%, and the cough may be absent, and that's a very high risk condition. When the patient is not able to cough and the vital capacity is much lower, the risk is very high, and the immediate management is required. Lesions at C3 or C6 lower the level, about 20% of the vital capacity may be maintained, and cough is weak and ineffective. They too require an immediate attention. With high thoracic injuries like T2 or T4, vital capacity is 30 to 50% of normal and cough is weak. Whereas lower cord injuries, the respiratory function doesn't change much after the initial phase of the shock. Then, or they may be normal. With injuries of T11, respiratory dysfunction is minimal, and vital capacity is essentially normal, cough is stronger, and that such patients do not require respiratory support. But analysis of these and whether the patient requires respiratory support or not is one of the critical issues in the management. The other complications which require an immediate attention could be the hemorrhage, hypotension occurring as a result of the spinal shock or neurogenic shock. Then hemorrhagic shock or neurogenic shock, they need to be immediately treated. Neurogenic shock due to the spinal injury is refers to a acute condition of hypotension, bradycardia, and peripheral vasodilation, which occurs due to autonomic dysfunction, and that autonomic dysfunction, particularly sympathetic nervous system dysfunction, after an injury is quite common, and it's just a response to the injury, which may be either temporary, transient for a few hours, or it may be for a longer duration. And the immediate, you have to give an attention to this immediately, and the patients may have to be treated either with the steroids or maybe adrenergic drugs to improve the condition. IV fluids also may be necessary. Spinal shock is considered to be a situation of a complete neurological functions, including reflexes, rectal tone below the specific level, even though the nerves at that level may not be injured. And this is a temporary phenomenon. Spinal shock is could be a temporary phenomenon. It may last for a few hours. Then there could be a spontaneous recovery from the tissues which are not directly injured but which are below the level of the lesion. They may recover, and usually there would be a phase of recovery from the neurological functions after a few hours. But during that early few hours, depending upon the severity, you may require a support, like if the patient has a urinary incontinence, catheterization may be required, bowel conditions may have to be managed with the soapodrome and so on. Then the usual course of the clinical presentation would be, patient initially would have a spinal shock where there is a complete loss of movement below the level of the lesion, complete loss of neurological functions, even the sensation may be affected. But gradually the patient may come out of the spinal shock and there could be a recovery. But during that phase, there could be edema at the site of injury, which may aggravate the symptom at that level. So usually the course of clinical symptom will be acute, severe, then there will be gradual recovery, then again there will be a worsening of the condition with the exact localization of the symptoms. That would be the typical presentation of a patient of spinal injury. Neurogenic shock occurs usually immediately after the acute spinal injury. Hypotension or shock with acute spinal injury above the level of T6 is very high, very severe, and which requires an immediate attention. If the level of injury is below T6, the hypotension may not be due to the neurogenic shock, it could be due to the hemorrhage. Now, if a hemorrhaginous shock is presented, then the patient requires volume replacement. Neurogenic shock requires the hypertensive drugs like methamphetamine or so on. So, to decide about that, this is one of the criteria. Then hypotension with a spinal fracture alone without neurological deficit or apparent spinal cord injury is invariably due to hemorrhage. If there are no neurological presentations, but a shock occurs at the spinal fracture, it's not due to the spinal shock, it's due to the hemorrhage only, and hence volume replacement would be the priority. Then patients with a spinal cord injury above T6 may not have the classic physical findings associated with the hemorrhage like tachycardia or peripheral vasodilation, and this sign should not be confused with autonomic dysfunction in such conditions. That's about the important guidelines during the management of acute conditions. Then the spinal cord injuries again could be categorized as primary or secondary. Primary is when the spinal cords are directly injured due to the trauma. Either it could be a complete transection where the spinal cord is completely cut, or distraction, or where the nerves are pulled out, or disruption where there could be somewhat edema or functional impairment. And usually occurs due to the fracture or dislocation of the spine. So, in general, as long as the spine is intact, the chances of injury to the spinal cord are very low, except in case of the vertebral column acute flexion injuries. Flexion or extension of the vertebral column may produce a spinal distraction without really having a fracture or the dislocation, which is comparatively less common, but still it is possible. But the general rule is when there is a spinal injury, there would be accompanying vertebral column pathology even, and hence from management point of view, that vertebral column pathology is given a greater priority to prevent further aggravation of the spinal cord injuries. Then epithelial hematomas or abscesses also can produce a primary spinal cord injury due to the compression. And spinal cord compression due to the metastatic diseases, tumors of the bone, also are common, and they are considered as oncological emergencies. Then, as I said, longitudinal distraction with or without flexion or extension of the vertebral column may result in primary spinal cord injury without spinal fracture or dislocation occasionally. Secondary injury, when it's produced with vascular injury, when the blood flow to the spinal cord is affected either due to injury to the arteries or thrombosis of the artery, or a perfusion is lesser due to shock, spinal cord injury could occur. Either it could be anoxia or hypoxia also. The usual terminologies used in case of spinal cord injuries are tetraplegia when all the four limbs are involved. The older term used was quadriplegia, but currently the term used is tetraplegia, not much of an issue, and they are common when the injury is in the cervical area, upper area. Paraplegia is when the injury is in the thoracic, lumbar or sacral segments, or cauda-equina or conus medullaris. The most common neurological injury is at C5. In paraplegia, it's around T12 and L1 are the most common levels. So, from the clinical point of view, these most common levels also are quite important. Based upon the clinical presentation, the clinical presentation of neurological conditions is considered at a different level, the syndromes depending upon the group of symptoms presented and depending upon the intensity of the injury. And it could be a complete cord syndrome where the patient may have complete loss of motor and sensory functions, where the continuity of the spinal cord at one segment is completely lost, and the level can be located exactly. You can point out the level where the complete loss of sensation as well as motor functions are lost. That's a complete cord syndrome. Anterior cord syndrome, where only the anterior tracts, particularly the descending tracts and ascending tracts of the anterior area, corticospinal tracts and spinothalamic tracts are involved. In such conditions, there will be variable loss of motor function. Some of the motor functions may be remaining, but voluntary functions may be lost. Temperature sensation also may not be, may be affected, but proprioception, position, sensation of the position may be normal. Then there is another called as Brown-Sequard syndrome. Now we will discuss some of these conditions in detail when we discuss about the myelopathy, the next part. There I will go into a bit more detail about these issues, which is often associated with the hemisection, half section of the spinal cord, and it involves a great loss of position sensation on the same side of the region, whereas pain and temperature sensation on the opposite side. Then central cord syndrome is due to usually in the cervical region, where there will be severe motor weakness in the upper extremities than in the lower extremities. So lower extremities may have somewhat motor functions left out. That symptom is called as central cord syndrome. And conus medullaris syndrome is where there is a sacral cord injury, with or without involvement of the lumbar nerve roots, and is characterized by absence of bladder reflex, bowel reflex, and to a lesser degree lower limbs. Lower limbs may still be functioning normal, but the patient may have only impairment of the bladder and bowel functions, which is called as conus medullaris syndrome, where the cauda equina area is involved. Then cauda equina syndrome is where there is injury to the cauda equina nerve roots directly, and it's characterized by again areflexia bowel and bladder, and motor and sensory loss in the lower limbs is lesser. So conus medullaris and cauda equina, they are very much similar. Now these are only for the assessment of the nerve injuries, which can predict the prognosis, location of the injury and intensity of the injury. The classical method of grading these injuries, again as I told you, chances of dealing with such acute injuries in our setup is lesser. Virtually you don't see many patients in our setup. Usually we refer the patients at that stage, but if at all you have to follow, that guideline is you have to follow a typical case sheet where each segment, each dermatome is examined and marked, and based upon that the condition is graded. The universal grading system, ASAA grading system, is a ABCDE. A suggests about where there is a complete loss of injury, complete loss of continuity of the spinal cord at the sacral segments. At the higher segments, where there is no sensory or motor function is preserved in the sacral segments. B is incomplete, where there is a sensory but not motor functions is preserved in the neurological level and extends through the sacral segments of S4 and S5. Incomplete is when motor function is preserved below the neurological level, and most key muscles below the neurological level have muscle power grade of less than 3. D is incomplete again, motor function is preserved below the neurological level, and most key muscles below the neurological level have muscle grade greater than that. E is normal. This is how it is graded as such, as a universal condition. Confirmation of the diagnosis is based upon the MRI image. MRI image is the best criteria to confirm the spinal cord injury, whereas the vertebral column injuries can be made out of the plain X-ray. The changes which can be seen in the spinal cord due to the injury could be, as I said, the edema. Edema would be seen as an increased opacity in the beginning, and it may just go on increasing. So it is a typical case, day 1 at the time of injury, edema. Day 3, after 3 days, the edema is increasing. Either it may be increasing or reducing depending upon the patient's situation. Or there could be hemorrhagic contusions. At the location of the injury, there could be hemorrhage. Hemorrhage would be seen as a opacity, increased opacity seen at the site of the injury, accompanied with a fracture. Hemorrhage may be, in due course of time, may be gradually reducing, size could be reducing or increasing depending upon the patient's condition. Or the transection of the cord, complete transection, cutting of the cord, the spinal cord may be completely torn off, and that tearing of the spinal cord is better seen after about 2 to 3 days. At the time of the injury, immediately day 1, the visibility would be lesser. There would not be much fibrosis or intense action. But later on, it may present with the higher intensity. The opacity can be better made out. Or it could be a compression of the cord due to narrowing of the spinal canal, which you call as the spinal canal stenosis, the usual term used, which could have many degrees. Spinal canal stenosis could be seen, and there could be a mathematical model of assessing the spinal canal as such. The management of a patient with spinal injury, as I told you earlier, the first thing is a pre-hospital management, where the patient is shifted to the area where the facility is available, which is a very sensitive job, and it should be that during the shifting the patient should not have aggravation of injury. And then the hospital care, the primary issues are airway management, as I told you earlier, then management of hypotension, hemorrhage and shock, and evaluation, neurological evaluation. And the other protocol of the treatment is steroid therapy, which is controversial now. There is an argument about whether steroid therapy is really useful or not, but still it's being used. Surgical intervention, mainly the spinal fixation, particularly if there is a possibility of vertebral column pathology, that has to be fixed so that the condition would not worsen. So that's about the management initially, and as I told you, chances of dealing with the patients at the initial stage in our setup is lesser. Complications which occur due to the spinal injury are progressive deterioration of the neurological conditions, pressure sores, aspiration and pulmonary complications, sepsis, hypothermia are the complications. You may get the patients, large number of patients whom you treat, they come with that later complications like neurological deterioration, pressure sores, or even pulmonary complications. Now, the neurological deterioration in course can occur as what we call as a myelopathy, which we will discuss somewhat in detail. Usually when the patient recovers, the common pattern of the recovery would be recovery of the ipsilateral on the same side of the lesion, extensor muscles usually recover earlier than the flexors. Then recovery from the weakness at the extremity with sensory loss before recovery occurs on the opposite side. The same side would recover faster. And the recovery of the voluntary motor strength and functional gain within 1 to 6 months is usually possible in case of spinal cord injuries. These are the usual patterns of the recovery, which can give you an idea like whether the patient is following this smooth course or not. Now, the delayed complications or a neurological deterioration which is produced due to the spinal cord injury is also named as myelopathy from our clinical point of view, because majority of the patients whom we treat with that spinal pathology, they are at the stage of myelopathy, and hence it's the most important condition. The causes for the myelopathy in general are spinal canal stenosis, injuries, infections, autoimmune pathologies can produce the myelopathy. Oncological tumor conditions, either secondarily or maybe due to the tumor affecting the vertebral column, can result in myelopathy. The neurological diseases or congenital disorders also can produce a myelopathy. The common types of causes are tumors, primary and metastatic, sclerosis, multiple sclerosis can result in myelopathy, disc herniation and spondylosis. Majority of the patients whom we see in our clinical setup are these two types. Herniation of the spinal cord through the dural defect, like after surgery, many times after surgery. Epidural hematoma, vertebral artery dissection, transverse myelitis, radiation during chemotherapy, management of the tumors, type 2 decompression sickness, like where the patient may have a sudden decompression due to either flying in a height or coming up from a high pressure area like a seabed. Then intravenous drug uses, tuberculosis, ossification of ligamentum fluum, which we have already referred to in the spondylitis conditions, meningitis, empyema, herpes, syphilis, ischemia, hemorrhages also can be caused by that. Now, the spondylomyopathy is categorized into 5 categories. Now, these are the same thing which we have discussed in the acute injury, but these are more categorized in case of the chronic injury. It's based upon the location of injury and intensity of injury. They are categorized into transverse lesion syndromes, where the corticospinal and spinothalamic tracts are, as well as the posterior columns are involved, where the patient may have complete loss of sensation and motor activity. Motor syndrome is when only specifically corticospinal tracts are involved and the anterior horn cells are involved, where the patient may have a normal sensation or maybe mildly impaired sensory pathology, but significant motor pathology. And when the sensory functions are present and motor functions are lost, there will be increased reflex activity. Whereas in a transverse lesion syndrome, because the sensory functions also are affected, though it is an upper motor neural lesion, the reflexes will be absent. Central cord syndromes are when particularly motor and sensory involvement is greater in the upper extremities than the lower extremities. Lower extremities may have a proper sensation, but upper extremities, they tend to have this. Brown-Sequard syndrome, unilateral cord lesion, which I just referred to, and I will have a bit more discussion about that. Then brachialgia cord syndrome is a predominant upper limb pain which is present. These are the typical presentation. Now, a bit more discussion about the transverse lesion. The transverse lesion syndrome is where the anterior corticospinal tracts, the descending tracts, and spinothalamic tracts are involved, and hence the patient will present with a paralysis on one side or a decreased motor strength and increased tone on the opposite side. That's the typical presentation. Whereas again, the transverse symptoms can present with the sensory tract, that ascending tract lesion, where there could be involvement of the lateral spinothalamic tracts, and hence patient may present with the absence of the withdrawal reactions, like painful stimulus from, and the patient may not be able to withdraw. That could be the presentation in some of the anterior syndromes. Then it's a central cord syndrome is a upper and lower extremity. I think that's what we have already discussed as such. Then Brown-Séquard syndrome. Brown-Séquard syndrome is due to the hemisection. Now, a large number of patients whom we see in our hospital, they would have Brown-Séquard syndrome as a consequence of the previous injuries, and it's usually due to hemisection of the spinal cord, where the patient would have loss of pain, temperature, and light touch, superficial touch on the opposite side of the lesion, whereas on the side of the lesion, the patient may have impairment of the deep touch sensation and this loss of vibration and motor functions as such. That's what we see. The typical examination would be that due to ipsilateral spastic paralysis on the same side, Babin's sign may be positive, and interruption of the posterior weight column on the ipsilateral same side results in the tactile discrimination, sensory loss would occur, and due to the involvement of the lateral spinothalamic tracts, contralateral loss of pain, and that's the pain and vibrative sensation on the opposite side would be affected. The major complications of all these myelopathies, so clinical signs of myelopathy are only the issue is they are the chronic complications which could occur due to multiple conditions. It's also a sort of spinal injury. Development of pulmonary infections or respiratory insufficiency, uncontrolled autonomic dysreflexia which results in bladder and bowel abnormalities, bowel impaction, urinary tract infections, pressure sores. These are the major complications which occur in the spinal cord injury, and majority of the patients whom we treat in our hospital, they would develop these complications quite frequently. And in such conditions, virtually from the current point of view, the treatment will be only the management of the symptoms and taking care of the physical needs, attempt for rehabilitation, and so on. So I will not go into that part. From our prescription, my prescription usually would be Chandraprabha Ekangavira, Abrakatapyadi Mishrana, which is commonly given, Rajayapan Basti or Dashamula Niruh Basti, depending upon the patient's presentation. If the patient has more of motor loss, Rajayapan Basti is given. If the patient has impairment of the sensory, Dashamula Niruh Basti is given. So it may be slightly changed according to the patient's condition. And though the patient will not be cured, many of the complications can be prevented, and there could be a marginal recovery in majority of the neurological symptoms. We have many patients who are able to now walk with support, where the patient was bedridden even after a complete spinal cord injury. So there is a significant advantage with our treatment protocol. With this, we will conclude the discussions on the neurology. Majority of the conditions related to the usual clinical practice are discussed. Hence, we will conclude today with the neurological condition. If there is any demand for any specific condition in the neurological conditions, we may discuss in due course of time if necessary. Otherwise, we will conclude. Then, in Yoga Basti Karma for Matra Basti, which oil do you prefer? Usually, I prefer Balataila Matra Basti. Balataila for the Matra Basti. In MRI, sacroiliac joint sometimes shows acute inflammatory or sclerosis or fusion. Now, if there is a inflammation, that's Amavata, and if there is a sclerosis and fusion, that's usually Kevala Bhattajanya or Dhatuk Shaijanya Vata Prakopa. And in Ama conditions, the usual treatment would be Agni Chikitsa and Kshara Basti, which we generally use in our hospital. And if in the later stages, of course, chronic conditions, Dhatuk Shaijanya would have a relatively poor prognosis, and the outcome also is poor, and the usual treatment is Brahmana Chikitsa, which we follow in our setup. I think that's about the questions and answers, right? So, okay, we will conclude, and we will conclude the neurology conditions. Next, of course, depends upon your demand, like which could be the next topic. Or if there is any specific topic in the neurology to be discussed, if you suggest, we can discuss that. Otherwise, we can continue, stop that. Okay, right, fine.